Kia ora. Electrical cardioversion is the use of an electrical current to revert a dysrhythmic tachycardia. This type of cardioversion is used in severely compromised patients, irrespective of the genesis of the tachyarrhythmia. That is to say, that is equally applicable for severely compromised patients who have any of the following rhythms: a ventricular tachycardia, a supraventricular tachycardia, atrial fibrillation, atrial flutter, and Wolff-Parkinson-White. The mechanism of action for electrocardioversion is the same as for defibrillation. The ensuing repolarization should also occur simultaneously, and it should follow the normal pattern, allowing an atrial pacemaker to become ascendant. The main differentiation between cardioversion and defibrillation is the use of a synchronized delivery system. The synchronization is an automated function of the defibrillator that ensures that the shock is delivered during the non-vulnerable portion of the cardiac cycle. In other words, it ensures that the shock is going to be delivered to avoid the terminal part of the T wave. This avoids this depolarization wave from occurring during the relative refractory period, where it might initiate further VF or VT. Two sets of modifiable factors contribute to the success of the cardioversion. So let's go on and look at these. The first of these factors are related to the delivery of the shock itself. And the critical element that we need to ensure is that the bulk of the defibrillator's energy is delivered to the myocardium. So, what we need to do is provide an excellent interface between the pads and the patient's chest. So, first of all, let's make sure the conductive surface is touching the patient's chest, and so you ensure that the pads are smoothed down onto a clean and dry, and if necessary, a shaved chest. Pad position itself appears not to be overly critical when it comes to cardioversion. Obviously the position has to be appropriate to the myocardium. However, there's not a lot of evidence to support the use of the anterior-posterior position in preference to the precordial placement. Either's going to be fine, but if you already have the pads on, it wouldn't be worth your time or the patient's time to change these around. Currently, the guidelines in Aotearoa, New Zealand advise the use of maximum energy settings on the defibrillator to ensure that maximum current is passed to the heart. The other area we can look to maximize success is to mitigate any underlying pathophysiology that's sitting behind the tachycardia itself. Where the tachyarrhythmia is the cause of hypoxia, or it has resulted in an altered level of consciousness to the point that the patient is unable to obey a command, reversion of the rhythm takes over all precedence. So in other circumstances, we might look to correct hypoxia or hypoperfusion, but in this one circumstance where there's an altered level of consciousness in a severely compromised patient, we're just going to go ahead and cardiovert. However, if the patient has a GCS of 15, we might look to reduce the sympathetic stimulation or alter the pathophysiology associated with hypoxia or low perfusion states. It really is advisable to address these where possible. This may mean maximizing oxygen delivery, having IV fluids running, or even providing analgesia or some degree of sedation to mitigate some of the sympathetic factors. Clinical judgment needs to be applied. It may not be possible to entirely correct all aspects of the patient's presentation prior to cardioversion, and it would be inadvisable to delay cardioversion in the severely compromised patient. So reversion of the rhythm takes over all precedence, and correction of hypoxia or low perfusion states may have to occur concurrently or even following the reversion attempt. Cardioversion is indicated for people who have severe levels of compromise. Patients who are moderately compromised tend to have markedly abnormal vital signs and may have moderate signs of myocardial ischemia. This may include refractory pain or ST segment depression on their ECG. As a rule of thumb, moderately compromised patients tend to look unwell but have a near normal level of consciousness. The severely compromised also have markedly abnormal vital signs, but the changes include overt alterations in their level of consciousness. A subset of those severely compromised patients is the ones who can obey a command. The vital signs are going to indicate decompensated shock, but their cerebral function is intact to the point that the patient can follow commands. It's appropriate to sedate these patients before attempting electrocardioversion. The other subgroup is those who are unable to obey a command. To all intents and purposes, this sign indicates a peri-arrest setting and the patient needs immediate cardioversion. Management of tachyarrhythmia by electrical cardioversion implies that you have assessed the patient and found them to be severely compromised. To recap so far, electrical cardioversion is the delivery of a synchronized electrical current to the myocardium of a severely compromised patient. We have an excellent mapping tool built into the CPG to assist in distinguishing between those who are severely compromised and those who are not. Electrical cardioversion normally involves the delivery of 360 joules of energy, and hence is an unpleasant and very painful experience. So, having established cardioversion as the appropriate treatment, the remaining distinguishing feature paramedics need to establish is whether the patient's going to require sedation prior to the cardioversion. The line in the sand is whether a patient can obey a command or not. If the answer is no, the inference is that there's a life-threatening hypoperfusion going on, that the patient is in the peri-arrest phase, and that cardioversion should be delivered without any further delay. If not, that is to say the patient is severely compromised but can obey a command, then sedation is the appropriate course of action to take prior to the cardioversion. And at this time, the expectation is to use a fast-acting dissociative agent such as ketamine. Having chosen the appropriate pathway, the next phase of execution is to prepare the equipment and the patient. For risk mitigation purposes, team members should know who is responsible for which task, so this information needs to be known by the entire team. So obviously someone has to be responsible for either confirming the pads are on and connected or to apply them. Someone needs to be responsible for the defibrillator setup and also for its operation. Someone needs to be monitoring things such as oxygen saturation, and someone has to be tasked with carrying on with some airway and breathing management should this be required. There's a checklist in the CPG covering a number of things to do and other things that need to be confirmed. So everyone should be familiar with this checklist, and I'm just going to summarize the main points here. In terms of what needs to be confirmed, we definitely need to place or confirm the pad placement. The other thing that requires confirmation is the patient's GCS. So this should be verbalized as part of the procedure. Now, this is going to confirm that the patient is either severely compromised with a lower GCS and we're on the right path, or it's going to confirm that sedation has had effect. The next thing we need to do is to switch the sync mode on and confirm that in lead 2 we have capture. This confirms that monitoring is being done via the leads rather than the pedals, and that the synchronization mode is well and truly on and engaged. And lastly, we need to go through the procedure to actually deliver the cardioversion. So this will require the defibrillator to be charged to the appropriate setting. For an adult, that's going to be 360 joules. We've still got confirmed capture, clear, and the shock is delivered. The final phase in terms of our to-do list is to check the patient's output and check their GCS. Reversion of the rhythm should hopefully resolve the GCS issues relatively quickly, unless the patient has been sedated, in which case we have to be very clear that we need to continue our SpO2 monitoring and perhaps provide supplemental oxygen or even some bag masking. If the rhythm doesn't revert, then we're going to have to repeat the procedure, starting back with the GCS check on the patient. So one last brief review of the situation. Remember, we would check the patient's GCS to ensure that they're unable to obey a command or that our sedation has had effect. We've confirmed the rhythm and engaged the sync mode. We've checked to see that we're in lead 2 and we have capture. We're charging to 360 joules because the patient is an adult. We provide an all clear. And now we would go ahead, check the GCS, ensure that we've got adequate oxygen saturation monitoring, and that we're providing any other supportive treatments we need to. This may include the administration of some analgesia. I hope this has proved to be useful. If you have any questions, please don't hesitate to contact me. Ka kite.